So thank you all for coming to this webinar, our monthly webinar on critical care topics. Today we have Dr. Jason Bartock with us, who is an intensivist and my teacher from Cooper University Hospital, and he is going to speak to us about approach to airflow obstruction. Thank you, Dr. Bartock, for joining us and taking the time to
Oh,
share
well,
your expertise.
yeah, absolutely. It's a pleasure to be here. Welcome everyone. I'm going to talk a little bit about non-invasive and invasive ventilatory support, specifically in the context of airflow obstruction. I think it's a little bit easier to anchor some of these concepts when we think about, how we're going to prescribe them for a particular type of pathophysiology. And in all honesty, it'll probably be airflow obstruction will be the most common reason for you to apply concepts in both non-invasive and invasive mechanical ventilation in your intensive care unit, similar to intensive care units here in the United States. Um, not that we don't utilize these modalities for for things like pneumonia or congestive heart failure, which I'm happy to comment on if there's any sort of prescriptive changes. But I want to try to simplify these concepts and talk about their application and maybe some of the troubleshooting and maybe even some of the dangers. I understand that folks on this call may be coming from different backgrounds. That's okay. If I come on a little bit too complex, I want to try to leave some opportunity for questions at the end. So let's just dive right in, and and then maybe for the next webinar, you guys can give me some feedback, and maybe we can change this up a little bit or even grow the topic. So let me just take control here. So no disclosures. And I want to be clear about the utilization of both non-invasive and invasive mechanical ventilation. I want to simplify it down to its overall purpose, because once you sort of, take a basic approach, and we talk about approaches a lot in critical care, it might not be a term everyone is familiar with. It's not algorithmic, but we build a systematic approach that we can take something that's relatively complex, and utilize best practices to build an application in a patient and then grow on that so that we're not bogged down by so much complexity, because all of you guys are really, really smart. And I think sometimes we overthink certain things when we don't have a simplified approach to start with. So non-invasive and invasive mechanical ventilation, whether it's its application really doesn't differ too much. The prescription may differ slightly based off of the underlying pathology, be it pneumonia or CHF or COPD or what have you. But the concepts, around applying a mechanical device to a patient in respiratory failure are the same. So I just kind of want to start off with, what is the purpose of non-invasive and invasive mechanical ventilation? And the purpose of it is to take over some or all of the work of breathing, right? When you're failing from a biological breathing system, you need to use a machine to take over that work. And then you'll augment that prescription based off of whatever the underlying primary driver is. Like I said, it could be COPD, it could be CHF. I should say it could be COPD and asthma, airflow obstruction. It could be CHF, core pulmonary edema, or it could be non-cardiogenic pulmonary edema, like what you would see in pneumonia and ARDS. The utilization of these modalities is the same. You're trying to take over the failing biological respiratory system, and you'll just have to decide how you're going to augment that prescription to either remain non-invasive or escalate to invasive support. So, for us here in the U.S., airflow obstruction, specifically COPD and asthma, are a real problem. It's still the number one cause for getting admitted to the ICU. And spending a little bit of time in DAR over the last couple of years, I can see that that you guys are having similar patient phenotypes, those who are exhibiting signs of respiratory insufficiency or failure related to obstructive lung disease, be it both COPD and asthma. And both of them still have a very high mortality associated with them, be it in the in the US or in the developing world. And I think as we build our approach to this, we always think about early recognition. We think about risk stratification, like where does a patient belong? And a lot of what we do in critical care is really surrounds this risk stratification concept. It's not so much what we can do all the time, it's how we can prevent bad things from happening. And then we'll talk about, the application of some of these modalities and hopefully, how we can support a patient until we can reverse the underlying, exacerbation, be it COPD or asthma, so that a patient can be discharged alive from the hospital. Airflow obstruction, be it COPD or asthma, we're just going to kind of use it as one overlapping term. Yes, you guys probably know even better than I do that these are slightly different in the primary drivers of what results in COPD versus asthma pathophysiology. But when it comes to the mechanical failing system, it's pretty much the same workload and failure from a respiratory standpoint, right? You have a high inspiratory effort that is matched by an even higher expiratory effort that then leads to a mismatch in what you're able to do in terms of support. You get air in, but it's hard to get air out. And that can lead to an increase in work, a worsening of the underlying system, be it dynamic hyperinflation. And then that can either impact hemodynamics, gas exchange, right, overall worker breathing, or in reality, what happens for a combination of all three things, right? So in terms of airflow obstruction, this cycle of failure, you start with an increase in inspiratory effort, right? You have your exacerbation of your underlying COPD or asthma, and that leads to dynamic compression, right? Because it's hard to breathe. You start to force air out, be it COPD or asthma. You start to air trap, and that dynamic compression then leads to alveolar hyperinflation, which then between the hyperinflation, the dynamic compression, it's harder for you to breathe out. That leads to lung hyperinflation. So now you have a system where you're hyperinflated and hard to exhale against. That leads to a decrease in overall thoracic compliance. And now that impacts your, the respiratory muscles that you started with. So now you have a failing, muscle system and a failing compliant system, and that then compounds overall worker breathing because you have to ramp up your work in order to then combat dynamic hyperinflation of the lungs and an increase in airflow resistance. And then you have to increase your work to deal with it with dynamic hyperinflation and an increase in resistance until you get to that whatever static inflection point exists within your patient to where they just fail on you. And there's a lot that we can do, or early recognition of the failing patient, right? Which is what you guys see. So you diagnose them with an acute exacerbation of their airflow obstruction. Then you apply medical therapies. We all understand that, a lot of this is driven by some sort of, inciting event, be it, hyper-inflammatory response or, or maybe a trigger of infectious etiology. But all of those things take time, right? Your bronchodilators will take time, hours, sometimes to work. Your corticosteroids will take time, sometimes hours to days to break some of these cycles. So in order to buy time for your patient, you're going to have to offload that worker breathing until those medical therapies can start to take effect. And that's the utilization of some of these mechanical modalities, be that, non-invasive with bilevel ventilation or invasive mechanical ventilation. So you guys understand concepts related to airflow obstruction. And these two diagrams here are just to sort of show you as measured in the patient, how severe, right, this sort of work and exhalation cycle can be, right? you see your COPD patients, and I think even for a lot of our doctors here, because more often than not they get better, you can almost, start to under risk stratify the severity until you meet someone that is very, very difficult to break, and they really humble you when it comes to this idea of how much motor output is required to overcome resistance so that the patient can continue to breathe and don't stop breathing on you altogether. And until you meet somebody, and I'm sure many of you have seen those refractory status asthmaticus or those severe COPD patients that you probably anticipated would turn around right away, and they did not. And then, if you aren't really in tune with their need, what their underlying motor reserve is, right, or the mechanics that they can generate on their own to exhale past this airflow obstruction versus their innate drop in overall diameter or increase in total lung resistance, you may underappreciate that, and that could lead to a delay in you escalating care to non-invasive support or invasive support, and that could be tied to poor outcomes. Down in this bottom left-hand diagram is just, maybe many of you, probably most of my fellows, have never really looked at esophageal pressure manometry as it's related to flow. I don't want you to spend a lot of time looking at that, but on the, you have these four little plots of red diagrams, right? The very bottom plots are esophageal pressure manometry. Those are actual pressures measured in the thorax, right? And then you have flow above it. And this is just showing you, in a relatively stable COPD patient, the escalation of muscle activity that's required to maintain work or breathing, right? So and it's a little bit hard to appreciate, but on the far left side, you see a relatively low, that's PES in centimeters of water, that's esophageal pressure manometry, a relatively low pressure in this stable COPD patient, and a relatively stable flow pattern above that when they're exhaling. And then in a pretty simplified, exacerbation, when you jump over, you can see a big spike, right, in the esophageal pressures or the thoracic pressures, and a big spike in flow. And that just sort of, allows you to appreciate how much jump in work for something that's relatively, that seems relatively insignificant, and how that can build over time. On the right diagram, again, showing you this inspiratory to expiratory flow pattern, right? The blue line shows you like a healthy individual, right? How easy it is during inspiration versus expiration up until you hit that plateau phase, right? Because all of us will have a limitation on how well we can exhale. And when it comes to airflow obstruction, this is a problem with exhalation, not necessarily a problem with inhalation, right? So your COPD and your asthmatic patients have pretty much, no or very little work to breathe air in. All of the work comes with trying to exhale, right, across, a fixed resistance, right, or a drop in total diameter across these small, medium, and large airways, right? So for all of us, if you guys take a deep breath in and exhale as hard as you can, we will all meet a limitation or a plateau phase. And you can see that in this V max, right? This blue line where it plateaus at the very top. Below that is where our classic COPD patient was, and you can see very quickly how they can hit that plateau phase, and that's indicative of the limitation, the reached upper limit of their expiratory phase, how quickly they can reach that plateau. And when you're unable to exhale and you're breathing rapidly and you're taking deep breaths, you will begin to breath stack over time. And then that will all compound on itself, adding to an increase in motor output to try to force air out against the fixed resistance, and patients will fail. So if all of you guys have made it this far with me and are totally confused, it's okay. I just wanted to hit some of these basic physiologic principles that probably aren't that basic, but just appreciate that this is a problem with exhalation. we're going to take airflow obstruction. And it's a great example of how a patient needs to have almost escalating muscle strength and motor response to work across a fixed obstruction, right? And a failing respiratory system is the result of that. And until medical therapies can take effect, you will often, right, have to overcome this failing system where motor output will be higher um, than air output with some sort of mechanical modality. And that will be the non-invasive or invasive mechanical ventilator, right? So here's a case: 62-year-old man admitted to your telemetry unit 2 days ago for chest pain. He has acute coronary syndrome workup, but it was mostly negative. So it doesn't look like an ischemic coronary event. Has a past medical history significant for chronic obstructive pulmonary disease and has an increasing shortness of breath over the past 2 days. You're called to the bedside. His heart rate's 122. His blood pressure is 140/90. His respiratory rate's 32 breaths per minute, and his temperature's 99 or 37.2 degrees centigrade. Arterial blood gas drawn by a respiratory therapist on 2 liters of oxygen. So there's a pH of 7.24, a PCO2 of 70, and a PO2 of 66. What is the best type of respiratory support to initiate at this time, right? So you have a 62-year-old gentleman, right, who comes in, for chest pain, found to not have an acute coronary syndrome, but is having worsening respiratory distress over the last 2 days. Now appears to be in significant distress with a very, very high respiratory rate and a failing gas exchange, right? So you see that based off of his blood gas, he is acidemic with an elevated PCO2. So what's the next best type of respiratory support to initiate for your patient? Would you place the patient on bilevel, non-invasive, positive pressure ventilation, high flow nasal oxygen? Would you jump to intubating this patient immediately and placing them on volume assist control, or would you cannulate the patient for veno-venous ECMO? ECMO tends to be a very hot topic. So I put that in there just mostly as a funny distractor. No one would put this patient on ECMO. The big question comes in: it's clear that the patient has a high work of breathing. So how can we offload that work of breathing? We also see that our patient has an impaired gas exchange, right? Predominantly an increase in CO2 retention. So how can we blow off that CO2? High flow nasal cannula, which I'm not going to get into too much, and happy to give a talk specifically on the utilization of high flow nasal oxygen, probably wouldn't be enough to offload work or breathing, as well as, allow for the enhanced clearance of carbon dioxide. So I'll just take that one off the table as well. And that leaves us with a choice for non-invasive support or invasive support. And I guess when you think about your ability to offload support, there's no perfect prescription, but this patient seems to have a reversible etiology. So when you think about the utilization of non-invasive support, we think about reversibility up front. So it seems like this could be acutely reversible if you're able to give bronchodilators, able to give him maybe, systemic corticosteroids. You might just need to buy a little bit of time to offload work or breathing without having to get overtly invasive. And we'll talk about jumping the gap between, non-invasive and invasive. But the best choice here would be the utilization of non-invasive bilevel ventilation, or BPAP or BiPAP, depending on what your brand is, right? So when it comes to non-invasive positive pressure ventilation, there really are two modes, right? You can get bogged down in all of the fancy machines, but you have continuous, non-invasive support, and you have bilevel non-invasive support. So this is a pretty good chart if you want to take a simplified basic approach and build on it over time, CPAP versus BiPAP or BPAP. The overall function of CPAP is to facilitate, a constant mean airway pressure per cycle of breathing, right? So CPAP is just a constant applied positive pressure. What will that do? Yes, it will offload some of the work of breathing, and you could, in theory, utilize it in this patient. The primary benefits of continuous positive airway pressure is to provide mean airway pressure, which can overcome some obstructive forces. Like if you have, obstructive, like OSA or a high boggy, oral pharynx in the proximal airway. And then it will provide mean airway pressure in the distal airways. So it can, force, interstitial edema back into where it belongs. It can provide that higher mean airway pressure allows for alveolar recruitment. One of the biggest effects of generating mean airway pressure is providing additional alveolar recruitment, which would be important in something like pneumonia or CHF, while allowing additional diffusion capacity, right, to provide better oxygenation. So from this type of modality, CPAP is a much better mode of support for both offloading work of breathing in the primarily hypoxemic patient. So maybe not the best choice in our patient from the previous question, because you know that patient, we do need to offload worker breathing, does not have a primary oxygenation issue, but does have a primary ventilatory issue. So BPAP or bi-level non-invasive ventilation allows you to create a diffusion gradient that helps you clear carbon dioxide. So within that modality, you have two things that are titratable. You have an IPAP and an EPAP. The same effect is you can decrease work of breathing, you can increase that mean airway pressure, overcoming obstruction, both proximal and distal, recruiting alveoli, which is good, allowing for an enhanced diffusion gradient for better oxygenation. That EPAP, right? The IPAP is the inspiratory force in which you apply. The EPAP is the expiratory force in which you maintain. So you can think about it, the EPAP sort of like PEEP. The IPAP is the driving pressure, and the differential between is the clearance gradient, right? So, not to confuse anybody right now, but if you're looking to clear carbon dioxide, you want to be able to generate a big tidal volume, and you want to have a high CO2 clearance gradient within your physiologic dead space. So that's the difference between IPAP and EPAP. So the larger, so if I'm on 10/5, my gradient is 5. So I'm able to generate a tidal volume and clear at a gradient of 5. If I want to clear more carbon dioxide, I want to enhance that gradient. So going to 15/5 gives me a gradient of 10, allows me to better clear carbon dioxide. If I want to enhance oxygenation, just like I would on the ventilator, I could increase the theoretic PEEP, which is the EPAP. So if I was on 10/6, I now have increased my EPAP, but just remember that overall gradient that you just built, right? 10/6 gives me a gradient of 4. So I could drop my carbon dioxide clearance. So what would I do to maintain that gradient is I would just go up. So 11/6 gives me a gradient of 5, which is the same as 10/5, but I have the benefit of a higher EPAP or a higher PEEP. So I have enhanced oxygenation. So that's a lot that I just said without being able to draw that out or show it to you on the BiPAP, but just use this as a working table, to think about um, your application for whatever titratable outcome you're looking for. Think about the function, the effect, the overall indications, right? How am I going to ventilate that patient, and what is the best way to ventilate that patient? You'll have much more, you'll have control over titratable variables of ventilation with BPAP that you don't necessarily with CPAP, while both can allow you for oxygenation. So the best mode to offload worker breathing and to enhance CO2 clearance in our previous example would be the utilization of BPAP or bi-level or BiPAP, or however you want to call it. We try not to say the term BiPAP because in the US it's actually a brand of non-invasive ventilator, but I think everyone uses it more or less interchangeably. If I'm losing people, please shout that out and stop me. Here's sort of a good thing, benefits for the utilization of non-invasive ventilation. Sure, we use it in pneumonia and other things, but the benefit seen from acute reversibility and enhanced survival you've seen predominantly in the COPD or obstructive airflow patient. It's also been proven in the CHF patient. And again, these are two patient populations where you've assessed and identified acute reversibility, right? The ability to turn a patient around within 24 to 48 hours, which isn't always the case with pneumonia. Do we use this as a modality to prevent intubation and to support a patient with pneumonia? Absolutely, we do. But the data is much more strong in the COPD and the CHF population. It decreases the rate of invasive mechanical ventilation when identified and utilized and titrated appropriately. It decreases the overall rate of treatment failure past that 24 to 48-hour period, which certainly in the COPD population, they're at high risk for relapse after 24 to 48 hours. So early initiation can reduce treatment failure and seen to reduce overall mortality. So the utilization of non-invasive ventilation, early recognition and titrating that appropriately, very important. Like I said, it can reduce the rate of intubation by almost 50%. So very powerful modality. Still, depending on the way the severity of your patient, the failure rate can exist anywhere as low as 5% or as high as 40%, depending on the patient population, right? So this really just comes in with, the concept of risk stratification and care escalation, right? When you identify patients who are at high risk for failure, they should be in a place where they can fail, right? You don't want to just put them in a non-monitored area on a machine when they're at high risk of failure, because when it comes time for you to reassess and possibly intubate them, you might not have all of the tools around you that you need. And that's what has a tendency to drive poor outcomes much more than the failure of the patient. It can often be the failure of the system. And your hospital is just like my hospital. I've been to your hospital. So your hospital is just like my hospital. Not every unit has everything that they need, and many units have very little, right, when it comes to rescue support. So risk stratification, important. We'll talk about that when it comes to predictors of failure. The concept of CO2 and CO2 narcosis, I don't want to get too much into it because I don't have a lot of time from pathophysiology standpoint, but certainly, retention of carbon dioxide, transmission of protons across the blood-brain barrier will increase cerebral blood flow. There is some swelling associated with that, some enhanced release of neurotransmitters, some augmentation of certain metabolic pathways, and a reduction in ATP production. All those things sort of translate into altered mental status, and that's what we're trying to combat over time. Is there a specific cutoff to where every patient will develop CO2 narcosis? Not necessarily. I think if you look at the data, really most patients, tend to be acidemic with a pH less than 7.1 and a PCO2 greater than 100. Is that for all comers? No. A lot of times the rate of change can be much more impactful than the overall number. Meaning, if I went from if for me, somebody who doesn't have, chronic CO2 retention, if I went from a CO2 of 40 to a CO2 of 90, there's a good chance that I'm going to be stuporous as opposed to the chronically compensated CO2 retainer who goes from 66 to 90, if you follow me. So the overall number maybe not as important, but certainly there's some big swings in the way that blood flow, ICP, neurotransmitter release, and overall metabolic demand and ATP change with changes in pH. So trying to get on top of that early can prevent the progression to CO2 narcosis and coma, which that has a tendency to be a big predictor on when you switch to taking full control with invasive mechanical ventilation. I don't know if you guys are familiar with certain risk stratification scoring indices. BPAP 65 is something that came up in the chest journal, a while back. I'll talk a little bit about them. But again, there's no best risk stratification scoring index to say this person will do well and this person will fail. But early recognition of patients at risk for failure, even if you just put them on simple settings, but put them in a place where they can be monitored more closely, they will have a higher success rate than patients who have low resources, who get put in a place where they have minimal monitoring, but still have a lot of these machines attached to them, which we see that all the time here in some of our community settings. you know, they have access to BiPAP. They put a patient on BiPAP. They just put them on the wrong floor, and there's nobody there to go back, reassess, and identify when a patient is failing. And then they have a major catastrophic event while on BiPAP that probably otherwise could have been prevented. This is a simple BiPAP screen. Every machine is going to look a little bit different, colors, waveforms, overall things. But like I said, down here in the bottom, that's the IPAP. You can set that as your total inspiratory driving pressure. Your EPAP, you can think about like your PEEP, your oxygen concentration, which you'll set. The respiratory rate, the patient will be able to predict their own respiratory rate, right? This is non-invasive. These patients should not be consciously sedated necessarily. But many of these machines will have an alarm system and a backup rate available, so that you can set that. But don't think that you're actually dictating an overall minute ventilation, because it being non-invasive, their inspiratory tidal volumes, their expiratory flow patterns, and overall rate, despite having a backup rate that you can set independent. And then you have an inspiratory timing. Um, uh, um, is delivered. And then it's something like airflow obstruction, where you're trying to maximize the expiratory time. Being able to dictate inspiratory timing may be beneficial. You can deliver a breath faster to allow more time for exhalation and feed some of that air hunger, which is something, as you get more comfortable with this, you may be prone to augmenting inspiratory timing a little bit to help the patient feel better supported and also facilitate more time for exhalation. Predicting success, I would say, as you become more and more comfortable with application and titration, if a patient is at risk for vomiting, non-invasive ventilation might not be a good modality for them. If they vomit into this mask, massive aspiration, I've seen it happen. So if a patient has uncontrolled secretions or prone to vomiting, this might not be a good modality to choose. You may escalate quickly to invasive ventilation because of a lack of airway protection. If a patient is comatose, you will see plenty of papers written about the application of non-invasive in the comatose patient. It requires a tremendous amount of nursing and facility support to ensure safety. So I would not just extrapolate that to your own practice. If a person cannot protect their airway, they should probably not be on non-invasive ventilation. We do see, it utilized sometimes, for patients who have like, psychosis, something that is probably going to be reversible within its 2 hours. But again, if I would recommend utilizing it in a comatose patient, they can be in a lot of distress, and we have a tendency to tie our patients down. You should not restrain a patient on non-invasive ventilation. Again, from a similar safety risk standpoint for vomiting and uncontrolled secretions, the patient finds themselves feeling nauseous or coughing and choking, they could be able to then remove this mask freely. And if we restrain the patients, we put them at very high risk. And then mask fit, one of the biggest, failures happen around patient comfort. So you have nasal, non-invasive, full facial non-invasive, which you can see the example in this patient. I don't know if anyone's ever seen one of these full face. get a good tweaking to make sure that it's too tight, that the patient is not overwhelmed with the sense of claustrophobia or anxiety, will really drive whether or not they can tolerate that. Think about what it's like to be in respiratory distress. I don't know if anyone on this call has ever felt like they can't breathe, but then, strap something on your face over your mouth and blow air in. I mean, think about what it's like to be riding on the back of a motorcycle, right? And you have all that wind in your face. Imagine what that would be like if you were in distress. It almost feels suffocating, although it's providing you with support. So one of the biggest predictors of failure often is comfort, anxiety, and claustrophobia. So think about mask fit and mask type. It might get you to the endpoint that you're looking to get to much easier, and has a lot less to do with the patient problem, more to do with patient comfort. When it comes to what is the best IPAP and EPAP to start from, nobody really has ever looked at this necessarily. I mean, if you go all the way back to protocols around implementation of non-invasive, you can look at the New England Journal of Medicine. Probably one of the last, papers that were published was in 1995. That's like an eternity ago in medicine. And really trying to look at the best way to go about it. I mean, start low and titrate up, right? I think that's the best way to do it. People have a tendency to look at someone with severe symptoms and automatically start with a severe prescription, right? You see somebody in respiratory distress and, you automatically start them on 20/5. Well, that might be, like I said, too much pressure for them. So take 30 minutes, hold your patient's hand, start low, and then start to titrate up every 10 or 15 minutes till you get your achievable goal, right? Which is a clear reduction in work of breathing, as well as an improvement in overall gas exchange, whether you're looking at that via end tidal capnography or via arterial blood gas. Does that make sense? I do think that we all have a tendency to start much higher than we should, and that can lead to patient failure because of discomfort. And is there a maximum that you can set your non-invasive to? The answer is no, but traditionally, like, a total pressure of 20 is probably the max that a patient can physically tolerate, or that the seal on a mask can tolerate, right? So somebody on 20/5 or 25/5 with a total pressure, driving pressure of 20 is probably the max that you're going to get without air leaking out of that seal. And then the tighter you tie down a patient's face mask, the more uncomfortable they're going to be, and the more prone to skin breakdown. So really, if they're failing upper limit pressures of around 20, they're probably failing, and you may look to escalate to invasive mechanical ventilation more quickly. Risk stratification, these are some of these scoring indices. I don't want you, if to immediately, adopt all of these, but just understand that there's, certainly things that people have looked at to say, well, who's going to fail and who's going to succeed when it comes to non-invasive. Some of the biggest predictors are always around age. And then some of these other risk factors, the severity of the overall dyspnea, some other organ system dysfunction. This was the BAP 65 classification. As you could see, patients with more and more risk factors had more and more mechanical ventilation escalation, more longer length of ICU stay, and overall mortality was higher. And really what it comes down here is to look beyond just pure respiratory systems, other organ dysfunction, overall age. All of these things play into the likelihood that a patient, number one, might need support longer, might need support at a higher level, is at higher risk of death and higher risk for escalation to mechanical ventilation. So this might be a patient, depending on the workflow of your hospital, that lands in the ICU, even if they don't look like they're going to be intubated up front, because they're at a high risk of failure. right? There's a number of other risk stratification scoring indices. This is another one. Takes into similar account the hardcore score for the utilization of non-invasive, and the higher you scored on this, the more likely it was that you were going to require, escalation and to invasive mechanical ventilation. So what I'm getting at here is, you know, look beyond, and it's hard for us sometimes to look beyond just the problem at hand. Think about the patient population that you're treating, what other organ systems are involved, identify somebody who might be at higher risk of non-recovery in that early acute phase, and put them in a place where you have everything around you that you need for more aggressive monitoring and then escalation to invasive mechanical ventilation. The biggest predictors of non-invasive failure really have a lot to do with with the degree of acidosis that you see up front. Failure usually occurs within that first 1 hour, and like I said before, has a lot to do with intolerance. Also think about, your patients who have very, very severe underlying pathophysiology, because they're also at risk for, rebound, both in your asthmatic population and in your COPD population. So they start to get better initially, and about 20% of your severe exacerbations will then experience a second episode of acute failure. Again, a good time where, like, somebody comes into the ED, they have bad underlying COPD. You put them on non-invasive, you give them, a first round of bronchodilator therapy. They start to look really good. You pull the mask off because you can dispo them to the floor. We don't need to admit them to the ICU. Well, about 20% of those patients are going to have a second episode, either day one or day two, of progression of symptoms, especially. And some of that falls into maybe they got better really quickly and you really pulled back your, how aggressive you were in treatment, and then they failed on you. So, think about the degree of, of acidosis, which is a good, sort of, identifier of both work of breathing and VQ mismatch. And then think about whether patients are at risk of failure, even if they're getting better, and may belong in a higher level of care, right? Which could be a sort of a step down level monitoring unit, or even in the ICU, depending on previous history. Watching them for that first 24 hours due to risk of relapse might prevent them from getting intubated, and certainly could prevent them from dying. Okay. So approach, like we said, benefits seen in acutely reversible conditions. Do we use it in other? Sure. Are you allowed to? Absolutely. Go all the way back to the very first slide. The reason why we use non-invasive ventilation is to take over some or all the work of breathing. That work can be generated from anything: CHF, COPD, pneumonia, ARDS. You're escalating to a mechanical support for a failing respiratory system. The benefits are seen mostly in COPD and CHF when it comes to acute reversibility, but can you use it? Absolutely. But think about where to put that patient based off of their risk stratification for progression, right? The multifocal pneumonia patient, is probably not going to get better in the first 6 hours of hospitalization. So they're at high risk for progression, especially depending on the time course when that pneumonia started, right? So they could get a lot worse. So put them in the right place, put them in the ICU if that's the best place for them. And oftentimes it is. Think about your contraindications from a safety standpoint so that you can feel confident escalating the rate to invasive mechanical ventilation. Think about your targets: work of breathing, right? Both CPAP and BiPAP are good modalities for offloading that mechanical work, right? For exhalation, or for both inhalation and exhalation. Think about the targets of both oxygenation, generating mean airway pressure, and carbon dioxide clearance, thinking about the overall driving gradient, right? Whether you choose CPAP or bilevel based off of your underlying pathophysiology. And then always reassess, titrate for comfort, titrate for endpoint, and then be ready to escalate to invasive mechanical ventilation and take over full, right, control, right, when a patient is failing, so that you don't allow them to continue to escalate and hurt themselves, right, which happens so often. So think about this 62-year-old patient. You put them on 10/5, 40%. Your repeat gas doesn't look any better. Actually, it looks worse, 718, 70, 80. How would you titrate? Well, you end up going up, to 20/5, right? And you think you do a great job of clearing more carbon dioxide. Well, it turns out you don't, right? The tidal volumes aren't much better. Their airflow obstruction is getting worse. They start to develop more dynamic hyperinflation of their lungs. So their alveoli are then starting to swell, which then results in more dead space, which then can actually inhibit, right, CO2 clearance, right, because the alveoli become hyperinflated and they crush those capillaries, and those capillaries are what end up releasing carbon dioxide into the alveoli so that you can breathe it out. So as you become more and more hyperinflated, you end up, developing more and more dead space ventilation, which is a very, very dangerous place to be in airflow obstruction, because again, you can't breathe out. So every time you breathe, you stack, you swell, you stack, you swell. And then eventually you get to a place where you can't exchange gas anymore and you die, right? So your patient now is showing signs of that. pH on the repeat, despite going up on your BiPAP prescription to 20/5, is 7.18680. So what do you need to do? Well, it's probably time that you took over full support, put them on a ventilator, and see what you can do to offload the work on the ventilator. Now, I only have about 13 minutes to go through some of these concepts in airflow obstruction and mechanical ventilation, which probably deserve an entire hour unto themselves. But the ventilator can be a very scary and potentially dangerous mode of support, because you have someone who has airflow obstruction, they have difficulty breathing out, and now you're forcing air in. So again, when you think about both your asthmatic and your COPD patient, air is going in, but air is not coming out. So one of the biggest problems here is about expiratory timing. And when you put them on the ventilator, sometimes these patients do a lot worse, especially your asthmatics. They can have worsening bronchospasm. Your airflow obstruction patients, based off of your inspiratory to expiratory timing, right, or your flow patterns, can actually breath stack worse, right? So, in these situations where you put them on the ventilator, your work is not over, right? Now the work oftentimes becomes more labor intensive when it comes to augmenting the breath so that patients can better exhale. You can reduce this air trapping. You can allow timing for your medical therapies, your bronchodilators, your systemic anti-inflammatories to take effect while the patient doesn't go into both a gas exchange cycle of deterioration, or due to really, really high intrathoracic pressures, result in in barotrauma or lung injury, and even, right, precipitate worsening hemodynamic collapse, right, due to and high a reduction in venous return due to high intrathoracic pressures or a high right ventricular afterload. Again, a talk for another time, but be prepared to intubate someone and then have things get a little bit worse before they get better. And in building your approach to invasive mechanical ventilation in the severe airflow obstruction patient, your only job is to think about all the things that you can do to optimize that expiratory phase, right, so that you can help alleviate those reasons why they might not be getting better immediately or potentially getting worse up front. Okay, I think I've kind of cycled around that, but dynamic hyperinflation and intrinsic PEEP is a real problem, right? Again, you can't exhale. So you blow in a tidal volume, a patient can't exhale, the lungs become more hyperinflated, the air sacs grow, they result in worsening gas exchange, due to a higher and higher intrinsic PEEP. And then how do you blow out against that? One of the biggest things that you can do is reduce the respiratory rate. You can deliver the breath faster so they have more time for exhalation. These are the biggest targets that we have, right? So, getting if you're able, right, through permissive hypercapnia to reduce a patient's respiratory rate to around 10 to 14, this will allow you to target an inspiratory to expiratory ratio of 1 to 3 or 1 to 4, really in severe airflow obstruction. I just had a patient this past weekend with severe asthma exacerbation that actually ended up failing even mechanical ventilatory support. Had them on an inspiratory to expiratory ratio of 1 to 5 and still could not fully exhale within that time frame. And that led to breath stacking and worsening gas exchange and then worsening hemodynamics. So really, you have to be aggressive up front about reducing the total breath timing so that the patient can fully exhale, so that breath to breath, every breath that you give the patient, you allow them to fully exhale that breath. And that prevents auto PEEP, right, or breath stacking, and also allows you to better clear carbon dioxide. So we do that by reducing the respiratory rate, which is the most powerful thing that we can do, but you may be limited due to pH. And you can also increase the inspiratory, you can change the inspiratory timing by decreasing the inspiratory time and giving the breath faster, right? So rather than having an I time of 1 second, you can deliver that breath over maybe 0.7 seconds. This might be a little bit more advanced when it comes to mechanical ventilation concepts, but think about delivering that breath faster. Again, that will cause your peak airway pressures to go up, but your plateaus will remain the same. And you don't really have to worry so much about those peak airway pressures. What matters most is allowing the patient to fully exhale. This little circle here highlights breath stacking. You can see the top waveform is inspiration, the bottom waveform is exhalation, and you can see where that circle highlights, that little red circle highlights that the patient doesn't fully exhale before coming back to baseline, and that little bit of tidal volume that's left over ends up remaining trapped in the lungs, and that's a big problem when you're breathing 40,000 times a day, right? This is another good example of that. You can see here, building that approach, you really want to try to limit this auto PEEP, right, or breath stacking, and allow your patient to exhale fully. It's not always easy to appreciate this at the bedside. I'm going to rattle through this example really quickly. You have a 70-year-old male who has an acute exacerbation of COPD. You know that this patient's maximum expiratory flow rate is 0.25 liters per second. You actually got this I got this off of the patient's PFTs. So based off of this, you're trying to figure out, am I breath stacking to a decent degree, right? So I can see it present on this waveform. It's not coming back to baseline. So let's just give this example. The patient's giving 500 milliliters of tidal volume. Their respiratory rate currently is 30 breaths per minute. They're on an IDE ratio, that's the inspiratory to expiratory ratio timing at 30 breaths per minute is 1 to 2, right? With a 2-second breath, right? 30 breaths per minute, right? That's that's one breath every 2 seconds, with this expiratory flow rate of 0.25 liters, which is 200 mLs, right? So a respiratory rate of 30 equals a 2-second breath. An IDE ratio of 1 to 2 then gives me just follow along with me. I'm probably crushing you guys right now, but just follow along with me as this example that breath stacking can be missed very easily. Inspiratory time is 0.66 seconds, and the expiratory time is 1.34 seconds, right? 2-second breath, 1 to 2 IDE ratio. I have 0.6 seconds for inspiratory. I have 0.34 seconds for exhalation. So you inspire 500 mils, right, in that breath. In 1.34 seconds, you only are able to exhale because of your maximum expiratory flow rate of 250 mils per second. You're only able to exhale 335 milliliters which means that you, oops, oh, there we go. You end up trapping 165 milliliters with every breath. And that's significant, right? That's significant air trapping, and that can lead to dynamic hyperinflation and total respiratory and cardiovascular collapse over time. So the best thing that you can do in a situation like this is work on all of your approaches to maximize expiratory timing. The most powerful thing that you can do is reduce the respiratory rate to allow the patient to exhale more. You can decrease the tidal volume, and you should try to decrease the tidal volume to target, a survivable pH, which would be, for most of us, a pH of 7.2 or greater. You can change the inspiratory time by delivering a breath faster. This one's already 0.6 seconds if you look at the I time on this ventilator graphic. So that's pretty fast. You're not probably going to be able to deliver it any faster than that. And then there's a question about PEEP. And I think this is something that, that folks can find themselves maybe doing the wrong thing. I've seen people reduce PEEP in your asthmatic, and PEEP application or applied PEEP, because you're worried that I have a high intrinsic PEEP, right? My alveoli are swollen, and especially in COPD, there's a lot of heterogeneity around that PEEP. And I'll give you the example here. You have a high intrinsic PEEP. We measure our intrinsic PEEP by getting an end expiratory pause, right? And that'll give us our total PEEP, and we subtract the applied PEEP on the vent, and that gives us our auto PEEP or our intrinsic PEEP. And we're targeting an intrinsic PEEP less than 8 centimeters of water. And how do we get more of that PEEP out of the alveolus, right? Let me skip this one real quick, because this high intrinsic PEEP will lead to more work of breathing in your patient. And these are a number of reasons why. It'll lead to more ventilator asynchrony and the requirement for more sedation and potential paralytic. It can also lead to big changes in airflow, obstruction, and gas exchange, because the alveoli will become swollen. They're going to clamp down on those capillaries. You'll develop more zone 1 lung, if you're familiar with zone 1, zone 2, and zone 3 physiology for alveolar ventilation. You'll have more zone 1 lung, where you have more hyperinflation and less blood flow, and that will lead to more VQ mismatch. So it can be very dangerous. And one of the ways, I don't have time for this explanation, but this is a real patient who was in an acute exacerbation of underlying COPD, had worsening dead space ventilation due to alveolar hyperinflation. And one of the things that we did to improve the patient was actually add more PEEP. And it almost seems counterintuitive to add PEEP to somebody who has an elevated intrinsic PEEP, but applied PEEP will reduce intrinsic PEEP via this, this explanation, right? We're applying end expiratory pressure. And I think for a lot of people, who are trying to simplify it in their mind, if I'm adding pressure at the end of a breath, won't that impede my ability to breathe out? And the answer is no. And it's a little bit complicated to explain the physiology behind that, but sort of this waterfall effect is something that you should just cement in your understanding. Like when you see a waterfall in nature, right, the waterfall will continue to flow forward even as the pool underneath of it continues to grow in volume up into a critical pressure. And the same thing that you can think about with applied PEEP. As I give additional PEEP, I'm not going to block the expiratory flow of the patient. One of the things that I will do is I'll better tent open the airways so that the back pressure can better be released. So this is a good example here of high intrinsic PEEP. You see these alveolar units on the left side. You have an intrinsic PEEP of 3, 5, 8, and 15. This is what it looks like a lot in COPD. You have some very, very inflated alveoli that are doing a very, very poor job of deflating and participating in gas exchange, and you have other ones that are doing relatively fine. The idea of applied PEEP will decrease work of breathing in your patient and allow for better exhalation by tenting open airways. So, they've studied this and they've shown this in a number of different examples. This is a picture of an inhaled radioisotope in patients with COPD, and you're just looking at applied PEEP, and you can see better ventilation going to the patient with no PEEP. I mean, with the applied PEEP of 10 versus no PEEP, right? And again, this is an effect that's seen in many patients with COPD, where you can add additional applied PEEP to help better improve their gas exchange. Does it happen for all patients? No. There are some patients that you'll apply PEEP to and it will do nothing for them. There are some patients that you'll apply PEEP to and it will be beneficial. And there were some patients where it will actually worsen hyperinflation. That's the A, B, and C patient in this. So again, it's not a set it and forget it type of phenomenon, but think about optimizing your PEEP for airflow to the way that we do it for patients with ARDS. So I'm running out of time here, but as you escalate care to invasive mechanical ventilation, remember that patients will often do worse before they do better. Your job is to minimize dynamic hyperinflation or intrinsic PEEP, and you can do that by limiting breath stacking, right? Treat the underlying cause and think about applied PEEP to allow for better expiratory emptying of the alveoli. Decrease your respiratory rate, decrease your I time, which is mean deliver the breath faster so you have more time for exhalation. And then if needed, think about how much air you're introducing if you're able to decrease your tidal volume. But the most impactful thing that you can do is decrease your overall respiratory rate. You can use a decelerating waveform, which will allow you to have higher delivery of the breath early in the breath as opposed to a constant waveform that we see in most volume control modes of mechanical ventilation. This will allow you to be able to give the breath, at the beginning of inspiration, most of it, so that allows for more time for exhalation. Take control, prevent dysynchrony, allow the patient to fully exhale. Many of these patients who are severe are going to need high dose sedatives and oftentimes paralytics in order to take full control. Think about your applied PEEP versus your intrinsic PEEP and be ready to match. We already talked about that. Keep those plateau pressures safe. I'm not worried about peak airway pressure. Like the patient I cared for over the weekend had a peak airway pressure of 55, but the plateau was only 20. This is all resistance. It's not going to damage the lung. It's just a matter of overcoming the trans airway pressure, which is not indicative of the compliant compartment. We talked about narcotics and paralytics. There are a lot, I'm not going to get into the medical management of airflow obstruction. There's a lot of things that you can do. I sort of ran out of time. Be cognizant of beta agonists, and especially in your asthmatics. This is a good example of someone I just saw on the floor, 29-year-old female with poorly controlled asthma. Comes in, has a pH and a PCO2 that doesn't look great, 7.16, 70, and 66. Gets albuterol nebs and placed on BiPAP. Her respiratory rate goes up. So what is the first thing that the medicine doctor does? Well, the patient's more tachypnic. I'm going to give more albuterol. The patient's respiratory rate goes up and the lactic acid is noted at 3. The medicine doctor thought that the patient's lactate was high due to a high mechanical load, so gave more beta agonists. The respiratory rate continued to go up, and the next pH was 7.01, 70, and 66. So now the patient had a worsening metabolic acidosis on their respiratory acidosis, and this is this concept of the beta agonist paradox. So be careful of that. Giving high dose beta agonists, escalating quickly to continuous beta agonists, may have the generation of lactate from beta agonist pumps. And that generation of lactate can then result in a metabolic acidosis, which your patient is already, who's already has a high work of breathing, will then work to combat a worsening metabolic acidosis by a higher respiratory rate, making them more prone to failure. So think about, beta agonists, and we can certainly overdo it with beta agonists. And even think about the fact that you can have a type 2 lactic acidosis through beta agonists, which can make work of breathing worse as a patient tries to compensate for a metabolic acidosis you're causing, right? While they already are trying to overcome what's necessary for their underlying either asthma or COPD. Other things to think about when it comes to offloading, helium oxygen mixtures are something that we do use sometimes in severe asthma. The utilization of 70% helium, 30% oxygen can create better laminar flow, specifically around turbulent areas and larger airways. The data is not good. I think once you've maximized out your medical therapy and your ventilator and your patient is still exhibiting signs of very difficult to control expiratory phase of ventilation, you may be left with trialing something like Heliox to allow a patient to better exhale. This may improve gas exchange. It may offload work or breathing, but the data is not very good. But you're not going to see randomized controlled trials necessarily in Heliox ad mixes. One of the other things that we've utilized to help break bronchospasms from a medical standpoint is isoflurane. So inhaled anesthetics are something that you can escalate to. Again, the data is not great, but it can help facilitate bronchial relaxation. And if you don't have the ability to escalate beyond your mechanical ventilator, utilization of inhaled isoflurane may be helpful. You can take your patient to the operating room and have your anesthesiologist put them on inhaled isoflurane, or you could bring your isoflurane machine to the ICU and switch your patient out. There's no standardized protocol to do this, but starting at 0.5%, titrating up to 2.5% until you see an improvement in their airflow resistance is really the best thing that we've done and other institutions have done from a protocolized approach. And then once you see those airway pressures start to get low and stay low below 40, you can probably start to titrate off your isoflurane. Not sure if anyone's ever used this in severe airflow obstruction, but when you sort of met your max on the ventilator, you might be left with some of these adjuncts. Not going to get into ECMO, but ECMO might be the last way that you offload that mechanical burden. Certainly there's case series in the utilization of ECMO for the refractory airflow obstruction patient who's not meeting what's required of them from a gas exchange standpoint on the mechanical ventilator. So I know I ran over a little bit and I apologize. Simplified approach: recognize the need to offload work or breathing and select your best modality. If it's acutely reversible, non-invasive is often the best choice. And then, risk stratify, place them in at the appropriate level of care. So when the time comes that you need to escalate to invasive mechanical ventilation, you're able to do that early and safely. Maximize your underlying medical therapies throughout all this, right? Because the utilization of both non-invasive support and invasive mechanical ventilation is just to take over mechanical work until you can reverse the medical cause and then transition that work back to the patient. Invasive mechanical ventilation often starts with a lot more troubleshooting once you put the patient on the ventilator. So be prepared. Don't just walk away. Be prepared to take control and maximize the expiratory phase of ventilation so that you can prevent sort of the cyclical dynamic hyperinflation and high intrinsic PEEP that all too many people get stuck in once they invasively mechanically ventilate patients. Do everything you can to prevent dynamic hyperinflation. And when all else fails, think about other measures like helium admix, like inhaled isoflurane. And, I would not advocate to early ECMO in anyone. I think that with a very structured approach to non-invasive escalation to invasive, and then the utilization of medical adjuncts, almost all of these patients can be appropriately managed without the utilization of mechanical circulatory support. I'm sorry, I ran over. I talked about a lot of things. Questions, guys? What questions can I answer for you?
Yeah. Thank you, Dr. Bartock. So I know we rushed through the end over there. So I just have a very quick one. If
Yep.
you have a patient with a high CO2, but a normal pH, would you give that patient BiPAP?
Yeah, it's a great question. I think no, and I would only treat work of breathing in that patient. So if for a patient, and that's a great question, because it's also something that I think that a lot of people will call the ICU or call someone because they got a blood gas and they have a high CO2, so we're going to institute BiPAP. It's a great question. If a patient has an intact pH, they don't necessarily, they're renally compensated and doing fine. The only indication for bilevel and for me often is, like we said, to take over some or all of the work of breathing. CO2 retention, right, is a function of impaired, work of breathing, right? I can't exhale and inhale and exhale to the degree that I need to maintain, CO2 clearance and a normal pH. So that I need non-invasive to help take over that work, to help assist me to inhale and exhale appropriately to clear carbon dioxide. And somebody who's otherwise, compensated and doesn't have a high work of breathing, no indication for non-invasive in my opinion. Absolutely, that's a good question.
Thank you. Makes sense. So just to alert everyone that we will be having more dedicated sessions on ventilation and invasive in September, when we'll have our teaching critical care conference in Dar. So some of these teachers and lecturers will be around. So we'll get to more details then. But if anyone has any questions or comments right now, please, you can go ahead and mute yourself. And
may have been a little bit overwhelming. Also, the end of the day. Maybe next time I'll I didn't think I was going to have enough content, and then I ended up having too much. So I'll trim it down next time. But I do look forward to seeing everyone in September. And if there's anything that I can do in preparation to to help better convey concepts and maybe even get some more hands-on with these topics, please let us know as we sort of prepare for that conference.
yeah, feel free to email me and any topics that you want to hear about or discuss, even in the webinars or in the conferences. We don't have any more questions. I think we could stop here. Yeah.
All right.
All right.
It was
Thank
great
you.
to see everyone.
Thank you, everyone. Take care.